Good afternoon, dear colleagues and friends. I am very honored to participate in the ALMA course, and I would like to acknowledge the very good work you are doing at the ALMA to promote geriatric education. Today, I was asked to speak about nutrition and dementia, which is not a very easy topic because, as you know probably, the relationship between nutrition and the brain are very, very complicated, as shown in this slide. All the nutrients, carbohydrates, protein, leptin, vitamin, minerals are interacting with the brain functioning. And indeed, inflammation is playing a big role, and inflamed aging hypotheses are more and more going to intestinal microbiota and adipose tissue. But indeed, I will not be able to speak in this way. I will be more simple and dealing with very practical issue. The first one concerns the nutrition disturbances all along our life that could be a dementia risk. And if we are looking at the different modifiable risk factors of dementia, we know quite well them, but we have to underline that midlife obesity is a very high risk factors of dementia in later life, as well as midlife hypercholesterolemia and indeed diabetes. These three nutritional risk factors are included in a lot of other risk factors that you know very well: low education, sedentary lifestyle, midlife smoking, hypertension, late chronic kidney disease, old age atrial fibrillation, and midlife depression. So the three nutritional risk factors that I mentioned at the beginning were part of the cardio, neuro, and renovascular risk factors. And it is because we are fighting against these risk factors that the incidence of dementia is slowly decreasing actually. Indeed, diabetes is involved in the process of dementia. And it is well known that diabetes, type 2 diabetes, promote the process of Alzheimer's disease process. And this is known that several studies show that developing Alzheimer's disease is increasing by 50 to 60% in case of type 2 diabetes mellitus. And this frequency is so high that now it was proposed to speak about type 3 diabetes, which could be the link between diabetes type 2 and dementia. And risk factors were proposed, diabetes-specific dementia risk factors score, to really show how important is the role of diabetes type 2 in development of dementia. I will not insist too much on this point to speak now about the specific nutrients and diets intervening on dementia onset. And before starting enumerating the specific nutrient, I have to tell you that we have very few randomized control studies which are really very good. In fact, these studies are very difficult to conduct for different reasons. And these reasons are firstly that when you are taking one nutrient, this nutrient has very subtle effect. And this effect depends on the quantity and the duration of the eating habit of this nutrient. Secondly, each of us are different, and indeed, our brain reserve multimorbidities are to be considered. And within the randomized control studies, we have very often very small cohorts of patients. And then we have different types of disease, Alzheimer's disease, but also vascular dementia. And it is completely different to speak of the early life disease or the late onset disease and the severity of the disease. So indeed, what I will show you now will have a few contradictions because these randomized control studies are quite difficult to obtain and to be very sure. If we are going to this systematic review of 24 randomized control studies, it seems that omega-3 fatty acid, vitamin B, vitamin E has no effect, while isolated studies show the positive action of green tea extract, vitamin D, beta-carotene, blueberries, granada juice, fish oil, and also high flavonoid drink. So as said, the main problem is that we have the many confounder, including obesity, hypertension, global diet, but also the different studies have a different kind of methodology and are not really reliable. To show you to precise what I say, is in this slide, you can see that vitamin B has no effect. And immediately after, I will show you that vitamin B is estimated to protect dementia by 24%. So you can see that different studies shows different kind of results. But in fact, globally, the food who decrease the incidence of dementia are in fact unsaturated fatty acid, antioxidant, and Mediterranean diet. And I will come back on anti-Mediterranean diet later. The food who increase dementia incidence are aluminum, smoking, and low vitamin D. But as I told you, it is very, very complicated to have precise action of the different food on the brain, and particularly concerning food, vegetable, coffee, and fish. And concerning fish, a study published in 1997 showed, the Rotterdam studies, showed that in fact, if we are eating regularly fish, your chance of developing one dementia is decreased by 60%. Oh, fantastic. In fact, fish seems to protect the cognition decline. And an analysis of 7 cohorts from 6 studies examining the association between low and high fish intake shows that, in fact, if you are consuming around 1 gram of fish per week, this increment was associated with an 11 lower risk of incidental dementia, which is quite good. But the best is probably the Mediterranean diet. And as you know, in the Mediterranean diet, you have to eat quite frequently fish, but also white meat. You have to exercise. You have to eat a lot of vegetable and fruits. You have to add olive oil, nuts, seeds, and you have also to have a lot of dairy and avoid red meat, sausage, and also cakes. And indeed, you have not to forget that in the Mediterranean diet, you have to drink a glass of wine quite every day. This Mediterranean diet is very important for avoiding cognitive decline, and a pre-meditated Navarra study, randomized control study, with 522 participants, mainly composed by women at the age of 75, have 2 kinds of intervention. The first one, in one group, they have only a Mediterranean diet plus extra virgin olive oil, EVO, to compare with low-fat control diet. And the follow-up of this study was 6.5 years, and the analysis of this study include a lot of adjustment, as you can see on the left side of this slide. And the results are quite encouraging, showing that Mediterranean diet plus extra virgin olive oil protect of the decline of MMSE very significantly, and also the decline is a clock drawing score very significantly. So very good results when you are associating Mediterranean diet and extra olive oil. The same study showed that if you replace the olive oil by mixed nuts, the results are good, but less convincing than with olive oil. And indeed, there is a protection of the MMS, decline of the MMSC, and also a protection of the decline of the crop growing score. In fact, to summarize the action of the Mediterranean diet, you can say that Mediterranean diet delay the cognitive decline, and particularly delay the global memory decline, and delay the decline in executive function. But, in fact, there is no significant impact on the incidental dementia, and there is a controversial impact on the MCI on fate. In fact, now we are more and more associating Mediterranean diet with diet against systolic hypertension with a low amount of salt. And in fact, it seems that the DASH diet decreases the age-related cognitive decline and also have a very positive impact on the incidental dementia. Close to this DASH diet, we have the MIND diet, with a link between Mediterranean diet with low salt, but also neuropsychological stimulation. And you can see that in this cohort of 1,500 participants at the age of 81, mainly composed by women with a quite good education, you can see that high diet compliance avoid the decline in the cognitive global score, while low diet compliance is not active at all. So these kind of results are very interesting to show that we can influence the cognitive decline by modifying the diet. And to summarize what I told you, in a recent publication by Louis in 2020, a systematic review including 16 research articles and meta-analysis of 12 research articles, including 60,000 participants, you can see that relative to all adults with low diet quality or an healthy diet, adherence to a high diet quality or high healthy diet pattern decrease the overall dementia rate and decrease the Alzheimer's disease. And these results are very significant. To continue my talk, I will speak about the interaction between dementia and different kinds of nutritional issues. And we know quite well that, as I told you at the beginning, that obesity is a risk factor of dementia, and the risk factor of dementia is increased by 60% when you are obese. But we have not to forget that unintentional weight loss at midlife or late age is something that is very important to consider. And if we have a weight loss without any other medical cause in a patient who is aging, you have to think about MCI and the start of dementia. And moreover, we know quite well now that underweight worsen the dementia outcome when the dementia was patent. When you're looking at the mechanism explaining weight loss in demented patients, you have three major mechanisms. The first one includes the dysfunction of the ion channels, which increase the metabolism, hypermetabolism. The second mechanism is in fact the dysfunction of the brain hunger control centers, which decrease the nutrition intake and indeed decrease the energy intake. And thirdly, there is damage of the entorhinal cortex and the hippocampus, and this is linked to an hyperphysical activities, and particularly in dementia, wandering. So if we are considering weight loss in demented patients, you can say that the weight loss is a primary factor of dementia. But in fact, other factors secondary factors are also interacting with this kind of primary factors. And it is for this reason that we now consider weight loss as a non-cognitive manifestation of preclinical Alzheimer's disease. And as I told you before, weight losers show faster cognitive decline and faster longitudinal cortex atrophy. So when we are thinking about the secondary factors which are cause of weight loss, we have firstly to think about smell disturbances. And in fact, Alzheimer's disease and the different amyloid lesion, tau lesion are involving the olfactory bulb, and this lesion explain the anosmia that very often people with dementia and particularly Lewy body disease have. Another point are the problem of mastication problem and oral health problem. And we know quite well the clinical aspect of periodontal disease, but we very often forget that this periodontal disease is very associated with xerostomia, and xerostomia indeed increase ageusia, which and indeed is linked with smell disturbances. But another problem with periodontal disease is that very often one germ which is implicated is the Porphyromonas gingivalis, which is for a few people in cause in the onset of dementia. And the infectious hypothesis of dementia is something which is still accurate. So I think that this periodontal disease has to be managed very well in all patients with dementia. Another problem to explain weight loss in demented patients are the swallowing disturbances. And in fact, you see very clearly on this slide that severe dementia patients have a very high rate of swallowing disorders compared to low or moderate severe demented patients and with indeed normal individual. And this kind of swallowing disturbances are very important to consider because in home care residents, if 7 to 22% of the residents have this kind of swallowing disturbances, in demented patients, this incidence and prevalence increase by to 45%. So indeed, when you have a demented patient, you have to systematically evaluate the swallowing efficacy. But you have also to identify the nature of the disorder, and indeed, you need to find the best way to favor the eating and the feeding of the patient. We have a lot of different kinds of possible things to do, but in fact, the most important are the changes of food consistency. It is also to fraction the meals to 6 meals per day, to eliminate non-food items on the table, and also be sure that there is always one person close to the patient to avoid any problem with these swallowing disturbances. So after this kind of smell disturbance, ageusia, this mastication problem, swallowing disturbances, we have to think that very often demented patients present acute somatic disease or are suffering from psychiatric disorders, and both of them acutely modify the mobility. And particularly, the BPSD patient have wandering disturbances, and indeed, when they are wandering, they are losing weight because they are too active, as said before. We have also to think about adverse drug reaction, and indeed, about socio-economical issues which are not really very important in this context, but which exist, and we have not to forget this kind of issue. So now we have to think about what could we do, what kind of intervention can you promote for demented patients? And the ESPEN guidelines for nutrition intervention in demented patients are very clear. Firstly, nutritional screening of every person with dementia is very useful and needed. Close monitoring of the body weight. Eliminate all possible causes of malnutrition. The meals have to be served in a pleasant atmosphere. The amount of food has to be adapted. The caregiver has to support personally each patient with dementia. And indeed, caregivers have to be educated about nutrition to give the best nutritional supplements to this person. No caloric restriction is needed. Perhaps you can prescribe, but I did not do that until now, appetite stimulant. As I told you, recommendation for one kind or another of vitamin B, D or E or omega-3 is very difficult to be convincing on this topic, as well as for folic acid, copper, and selenium. And I told you that no, the data are very conflicting. But we need to have a tailored and personal nutritional intervention. And if needed, and only if needed, you can put one tube feeding for a limited period of time to pass a cap, for example, an infection. But you have not to leave this kind of tube feeding for a long time. And you have not to put any tube feeding in severely demented patient. So now I discovered recently that we can have an app which can help the caregivers to know exactly which kind of food you have to do to give to the demented patient. And it was quite surprising. If you are a carer of a demented patient, you can tell to this app what kind of food you have in your fridge, your food are available, and the app will give you the better advice to feed your patients. So the main problem of the food intervention is to know if they are effective or not. And a research performed in 13 databases concerning about 14,000 records and 300 full research. And full papers. And then the selection of 81 nutritional intervention, you can see that in fact, oral nutritional supplements have a small positive effect at short term, but the effect at long term is very unclear. Food modification that I spoke of before have a small effect. Dysphagia management have a low positive effect. And if we are giving an eating assistant, the evidence is inconsistent. The importance of the social integration and involvement is very appreciated and probably increase the quality of life. But the last days of life are very important to consider. And in this way, hydration and eating at the end of life is a very difficult topic. And it is depending of cultures and also of regions. And I will not speak too much on this aspect. We can leave it for the discussion. So what could be my take-home message after this presentation? The first one is to say that weight loss is a non-cognitive manifestation of preclinical Alzheimer's disease, and we have not to forget it. And if you don't find any explanation of the weight loss of an aging person, you have to think of the start of the onset of an Alzheimer's disease. Secondly, Important weight losers show faster cognitive decline and faster longitudinal cortex atrophy. The third point is that due to methodological issues and control for individual differences, diets and nutrients are not proven to robustly alleviate cognitive decline over short periods. And to last, I would like to tell you what kind of intervention we can have for demented patients. Firstly, you have to have an early detection of malnutrition using anthropometric measures, but also biological measures to know exactly the feeding behavior of the patient. You have to try to improve the daily dietary intake and take care of the possible side effect of drugs. You have also to consider the preference of eating of the patient. You have also to support, indeed, the functional disabilities of the patient, to go to do shopping for this patient, to adapt the food consistency, etc., etc. And to last, you have to treat and to reduce the different behavioral which increase the hypermetabolism and the consumption. And indeed, it is very important to do all this kind of tasks all over the age, the dementia process. And with that, I would like to thank you for your attention, and I will be pleased to try answering your different questions. Thank you again for your attention and for your invitation.